Good morning and welcome to the third global grand rounds of the American Academy of Otolaryngology Head and Neck Surgery for 2022. Today's topic is contemporary management of oral cancer. We're very excited to have a internationally renowned panel today, and we will get started with a few brief introductions. So I'm Mark Zaffirio. I'm the coordinator for international affairs for the American Academy of Otolaryngology Head and Neck Surgery. And first, we would like to hear a few brief words from our current president of the American Academy of Otolaryngology Head and Neck Surgery, Dr. Ken Yanagasawa, who is a international leader in the field of otolaryngology head and neck surgery. Dr. Yanagasawa.
Good morning, everybody, and thank you, Dr. Zaffirio, for the opportunity to say a few brief words. It is wonderful to see so many attendees from around the world convening to participate in today's Global Grand Rounds webinar. Building collegiality, new friendships, and novel diagnostic and therapeutic options make this event so valuable and enjoyable. Many thanks to our International Advisory Board, all members, and our dedicated staff for organizing this fantastic webinar. It is truly an honor and pleasure to collaborate with all of our international friends and colleagues. On a final note, I do hope that many of you will attend our Academy's annual meeting in Philadelphia in 6 short weeks, and I look forward to seeing many of you there. Thank you once again to everyone for attending and participating, and I look forward to this morning's presentations. Thank you.
Thank you, Dr. Yanagasawa. We are also honored to have with us this morning the CEO and Executive Vice President of the American Academy of Otolaryngology Head and Neck Surgery, a global leader in otolaryngology head and neck surgery education, Dr. Jim Denaney. Dr. Denaney.
Thank you, Mark. I appreciate being able to come on. This is another one of the great series of the Global Grand Rounds that was emanated from recommendations of our International Advisory Board. And the two chairs today, Dr. Masuo and Dr. Hao, I appreciate very much what they've done. Sheng Po is actually our incoming chair of the IAB and will take office in Philadelphia. Again, thank you all for supporting this. And even though this came up during the COVID crisis, I think the value is quite clear, and we plan on continuing these even as in-person meetings go on. Thank you again to the panel, and I'm looking forward to hearing this great presentation.
Thank you so much, Dr. Denaney. Today we have over 1,300 attendees registered from over 100 countries throughout the world. So we really look forward to all of your participation. Please put any questions or comments in the chat. You will also be getting a follow-up email next week, which contains some links to some of the Academy websites and events with important information, as well as, importantly, the certificate for this event. The educational certificate for this event will be emailed to you next week. So without further ado, to introduce our moderator, Dr. Sheng Po Hao, who is the professor and chairman of the Department of Otolaryngology Head and Neck Surgery at Shin Kong-Wu Ho Su Memorial Hospital and Fujian Catholic University in Taiwan. Dr. Hao needs no introduction, but just to say a few brief words. As mentioned, Dr. Hao is the incoming International Advisory Board Chair-elect for the American Academy of Otolaryngology Head and Neck Surgery. He has been a longtime supporter of the Academy with significant involvement over many decades. And he has also been involved in many other as a global leader in many other global societies, including American societies, but also as the founder and first president of the Asian Society of Head and Neck Oncology, which now has over 17 country members. So we're very honored to have Dr. Sheng Po Hao, and without further ado, we will move on to the session. Dr. Hao?
Well, thank you, Mark, for your kind introduction. First of all, I would like to welcome all the participants. Thank you for joining us for the Global Grand Round, Contemporary Management of Oral Cancer. This is Dr. Sheng-Po Hao from Taiwan. I will be your moderator today. I think everybody knows that cancer arising from the oral cavity is truly a global disease. It affects nearly every part of the world with 3 155,000 new cases and 177,000 deaths in 2018, which is around 50% survival, though we know that the 5-year survival is around 65% in America based on the sheer data. As you may know, oral cavity cancer is more prevalent in certain parts of the world, such as Asia, India, and South America. The clinicians there gather a lot of experience, especially on the advanced cases. However, the contemporary management of this global disease, oral cavity cancer, should not only focus on the clinical management. We should also look into different perspectives, such as molecular biology, epidemiology, etc., for prevention and for screening, which might further help our people. As oral cancer is a disease of diversity, I also intentionally invite some of the young and promising surgeons with their naive eyes to look into this important disease, and of course, along with some more experienced surgeons for this global grand round. I would like to introduce my co-moderator, Professor Jeanette Machuo from the Philippines. Dr. Machuo is currently the Chief of Head and Neck Division in the Department of Otolaryngology in PGH, the Philippine General Hospital, the Philippines, and Clinical Associate Professor in the University of Philippines in Manila. Professor Machuo, it's your turn.
Thank you very much, Dr. Hao, for the kind introduction. It is with great pleasure and excitement to be part of this global conference on the topic of oral cavity cancer, which is a big part of our practice, especially in this part of the world, in Southeast Asia. For the next 1.5 hours, we have prepared a well-packed and comprehensive program. We have 5 very distinguished speakers who have prepared their talks for you. And to get the conference started, let me introduce the first speaker. Our first speaker is from Taiwan, Dr. Chung-Yu Hao. He is an attending surgeon, an attending otolaryngology head and neck surgeon from the Shin Memorial Hospital in Taiwan. And he will be talking on the prevention, screening, and diagnosis in oral cancer, the Taiwan experience. Dr. Chung-Yu Hao.
Good morning, everybody. My name is Chung-Yu Hao from Xinguang Memorial Hospital in Taiwan. It's my pleasure and privilege to be here to share our Taiwan experience of oral cancer prevention, screening, and diagnosis. Oral cancer is a global critical health issue due to its life-threatening potential. Globally, estimate 0.4 million new oral cancer cases every year, and with the majority of them coming from Asian continent. Various factors such as genetics, microbiome, habitual, and lifestyle factors are closely associated with oral cancer occurrence and progression. However, smoking, fetal nut chewing, and alcohol drinking are regarded as the 3 main risk factors for oral cancer. HPV virus currently confirmed to be related to oropharyngeal cancer, but not related to oral cancer. Oral potentially malignant disorders such as oral leukoplakia, euphroplakia, oral submucosal fibrosis, and proliferative varicose leukoplakia are assumed to have high risk of malignant transformation. Oral punch or incisional biopsy should be a routine procedure in the overall evaluation of oral potentially malignant disorder to assess the presence of dysplasia, rule out underlying malignancy, and predict cancer progression. Early detection, prevention, and treatment of oral potentially malignant disorder are needed to prevent its malignant transformation to oral cancer. So in Taiwan, oral cancer is ranked number 4 incident and mortality rate in male, and over 7,400 new oral cancer cases are diagnosed every year, and 80% of oral cancer occurs in men aged between 30 to 64 years old. Sadly, more than 3,000 people die from oral cancer annually in Taiwan. Consumption of betel nut, cigarette, and alcohol is positively related with the risk of upper aerodigestive tract cancer. According to Health Promotion Administration in Taiwan, betel nut chewing leads to 5 times incident rates of upper aerodigestive tract cancer compared to individuals who did not use these 3 substances. And people who smoke, drink, and chew betel nut have 10.5 times chances to develop upper aerodigestive tract cancer. Early diagnosis and early treatment usually ensures better treatment outcome and survival. A comprehensive and effective oral screening program is necessary for high-risk population for oral cancer, which has greater chance to detect potentially malignant lesions and undergo regular follow-up under the oral screening protocol. Since 2007, Ministry of Health and Welfare in Taiwan set up the oral screening protocol for high-risk population of oral cancer. The protocol is a government-sponsored program with interagency coordination and take part in healthcare systems nationwide. Free oral screening is done by otolaryngologists, dentists, and trained specialists biannually for high-risk population to develop oral cancer. Target high-risk population included 30 years old above or abnormal people above 18 years old who chew betel nut or smoke. Inspection and palpation with additional special staining such as toluene blue over the whole oral cavity to detect possible oral cancer or precancer lesions. Oral lesions will be documented fully on the inspection sheet and be used for further follow-up references and referrals. People with normal oral screening result will be provided with further regular oral screening afterwards. People with abnormal oral screening findings are referred to medical centers for further evaluation and management. Both normal and abnormal oral screening results, betel nut and smoking cessation program will be arranged. Oral screening protocol was set up since 2007 in Taiwan, and 2 years after the standardized incidence of oral cancer began to stabilize. And from 2014, the incidence of oral cancer started to decline. Moreover, target population under oral screening protocol has 26% lower mortality rate compared to non-screen group. Population under oral screening program has a significant lower cumulative mortality rate of oral cancer, and a cumulative probability of survival are higher in screen detecting group than in non-screen group, which shows people under oral screening program has a greater chance to detect and treat early cancer for better outcome and survival. This proves that a comprehensive epidemiology oral screening policy can lead to patients' better clinical outcome and survival. Early prevention, early detection, and early intervention leads to better treatment outcome and survival for oral cancer. Thank you for your attention. This is my topic.
Thank you very much, Dr. Chung-Yu Hao. Please reserve your questions at the end of our last speaker. We will have our Q&A at the end of all the lectures. You may type your questions in the Q&A box. So again, thank you, Dr. Hao. Our next speaker, our second speaker is from the United States, Dr. Stephanie Chen. Dr. Chen is currently a fellow in the Head and Neck Surgical Oncology and Microvascular Reconstruction Program of the Department of Otolaryngology, Head and Neck Surgery of the Emory University School of Medicine in the US. And she will be talking on the molecular diagnosis of oral premalignant disorders and oral cancer. Dr. Chen.
Thank you so much. Let me just pull up my slides here. All right, thank you so much for having me. Today I'll be speaking about molecular diagnosis of oral premalignant disease and also oral cancer. I have no disclosures. So as we know, oral cancer is the 11th most common cancer worldwide, with the majority of incidence in low and middle income countries cited to be up to 67%. There are several risk factors, as Dr. Hao had mentioned. Some are dependent on geography and lifestyle. But as we know, smoking, alcohol, betel nut chewing, as well as poor dentition and even inflammatory disease have been associated with the developing oral cancer. From a geographical perspective, in Western countries, smoking and alcohol are the leading causes or risk factors associated with oral cancer, whereas in Asian and Pacific countries, betel nut chewing is the predominant risk factor, given that it's a larger part of culture there. Smoking is also a very common risk factor there, and less so alcohol. Unfortunately, 5-year survival for oral cancer is pretty low. Most studies cite 15 to 50%, mostly because patients are not diagnosed until they're at an advanced stage of disease. There are many reasons for this. First, the current diagnosis of oral cancer is completely reliant on our oral exam as well as biopsy, and also very dependent on the skill and experience of the examiner. We do know that oral cancer is often preceded by oral premalignant disease. So this includes lesions like leukoplakia or erythroplakia that are initially benign, but they have the potential for malignant transformation into oral cancer. Unfortunately, there's no standardized screening in the US similar to breast cancer or colon cancer. However, if we were able to diagnose these cancers earlier at an earlier stage, survival could be improved significantly to greater than 80% if it's in stage 1 or 2 category. This is where molecular diagnostics is very exciting, because if we're able to utilize this technology, we could potentially improve diagnosis and also treatment of these patients. So as you know, there are 4 stages of carcinogenesis. The first stage is initiation. So this is when a normal cell undergoes some sort of insult, like a chemical insult, such as betel nut chewing, radiation, virus. This leads to an initiated cell. Unfortunately, that cell is not able to undergo DNA repair. The second stage is promotion. So that initiated cell is able to survive and divide and become a preneoplastic cell, or in our case, oral premalignant disease. The third stage is progression, and finally metastasis, where it becomes a malignant tumor that's able to penetrate past the basement membrane and officially become an oral cancer. So each stage is associated with modifications in cell pathways. This is where biomarkers come in. These are basically cell components that are highly expressed in tumor cells. So you can capture these using a biopsy or an oral swab, or body fluids, so blood and saliva. And there are several biomarkers, including genes, nucleic acids, proteins, and enzymes. And we could potentially capture biomarkers at each stage of carcinogenesis, and therefore diagnose patients, especially who are at higher risk of developing oral premalignant disease as well as oral cancer, even earlier than we are now. So there are a lot of technologies that I won't go into too many details about, but technologies that are able to allow us to process, extract, and quantify genes or proteins such as PCR, sequencing techniques, Western blot, enzyme assays, etc. So there are several advantages of molecular diagnosis. First is it allows us the potential to enable an earlier diagnosis and possibly develop a screening process. Second is it's very non-invasive with an ease of diagnosis. So if we're able to use oral swabs or collect saliva or blood, it's a lot more feasible and easier to implement compared to having to achieve a pathologic biopsy. And finally, molecular diagnostics allows us to help predict prognosis and therefore inform treatment, monitor therapy, or monitor for recurrence. So just to show you some recent studies, there are several proteins that have been identified as potential candidates. So in the oral tissue, cytokeratins, EGFR, in saliva, MMP, vimentin, and in blood, haptoglobin. And among nucleic acids, P53, microRNAs, and other epigenetic modifications like histones. And finally, just some examples of studies looking at specific biomarkers. One study showed that Notch1 mutation, Notch1 is important for cell signaling in cell proliferation. This mutation was identified in 10% of tumor samples and was associated with oral cancer proliferation as well as progression, so a marker of aggressive disease. In another study, P53 was associated with the development of oral cancer in younger non-smokers. Another study showed chemokine ligands such as CXCL10. That upregulation was associated with worse survival, as well as worse response to radiation in the adjuvant setting. And finally, bacterial DNA have also been investigated in saliva samples. One study showed that the presence of a specific bacteria called Firmicutes phylum that was found to be expressed in high levels in oral cavity cancer patients and not present in controls. So overall, there are many exciting developments for future studies. For now, there are a lot of ongoing studies to continue to identify prominent biomarkers associated with both oral premalignant disease and oral cancer. Unfortunately, at this point, there are no markers that have shown utility in screening or diagnostics yet, but large prospective studies are necessary to help understand their significance. Some groups have also started using AI or artificial intelligence to try and develop a treatment or risk algorithm prediction model to help predict which patients are at risk of developing oral cancer based on patient characteristics, looking at final pathology and oral cancer-related gene variants. So in conclusion, our current diagnosis of both oral premalignant disease and oral cancer relies completely on oral exam as well as a tissue diagnosis. Molecular diagnostics is very exciting because it does hold the potential of allowing us to enable an earlier diagnosis and help monitor progression, treatment, and recurrence. It also would allow us to have an increased ease of use and therefore generalizability with minimal training required to obtain just oral swabs and blood and saliva. And finally, larger prospective studies are still necessary to help improve our understanding of the role of molecular diagnostics. These are my references. Thank you so much.
Thank you very much, Dr. Chen. Some have already posted questions in the Q&A box. Our speakers will try to answer them, send their answers privately, or and some we will be discussing during the live Q&A portion. Thank you again, Dr. Chen. Our next speaker is from Malaysia. Professor Mohd Razif Mohamad Yunus. He is the current president of the Asian Society of Head and Neck Oncology. He is also a professor and an attending otolaryngologist head and neck surgeon from the Pusat Perubatan National University of Malaysia. And Professor Yunus will be talking on recurrence in early tongue carcinoma despite well-executed glossectomy. Professor Yunus. Razif?
Right. Thank you very much, Professor Jeanette, Professor Shin, and American Academy for having me to give some of my thought on this topic. So I'm going to talk, share some of points on recurrence in early tongue carcinoma despite a well-executed glossectomy. You know, if you have a patient with a small tumor and we perform a surgery and they tend to come back. So I think it's important for us to look clinically why this thing happened. So this is where I work in Malaysia. And as mentioned by the previous speaker, the incidence in Malaysia is not that high in terms of incidence of carcinoma of tongue. or oral cavity lies between 11 to 12 in terms of the incidence. So we have a small study to show that in 72 patients that we treated, 38% developed recurrence or residual post-treatment. And we know that if you have an advanced D stage or perineal invasion, they tend to have recurrence. But what about in early stage? So in terms of success of the treatment, especially in this topic of oral cancer, I would like to divide into two. One is we talk about patient-related factors, and number two is tumor-related factors. Because despite an early stage of tongue carcinoma and well-executed glossectomy, we are still facing recurrence. So if we're talking about a patient-related factor, we always talk about age and gender. However, when we look at the literature, there's a conflicting results. There's not really showing whether it's true age and gender really influence or not influence in terms of outcome of the tumor. However, tobacco, smoking, and alcohol, this does have influence in terms of treatment. So if you have a patient with these bad habits, they tend to have a poor prognosis and they have to have a high incidence of recurrence. Same goes to bitter nut chewing and lower socioeconomic group. And last is about comorbidity. So we have a patient with moderate to severe comorbidity. They were about 4 times more likely to have a worse survival compared to those who don't have any comorbids. But what more interesting is the tumor-related factors. This is something that after we have resected the tumor and we look into the histology, we know that if you have a high stage and nodal involvement, the recurrence is high. But I think it's more important for us to look more in the histology. We're talking about tumor thickness and depth of invasion, and this is usually interchangeably in literature. So if you can look at the photo on the top there, the difference between tumor thickness and depth of invasion, you can in a flat tumor is same in terms of the length, and we have an exophytic tumor, tumor thickness is more than depth of invasion, and you have an ulcerated tumor, tumor thickness is less than depth of invasion. So again, if you have a big tumor in terms of size, then you can have a poor prognosis. More than that, degree of differentiation, we also need to look at what type of differentiation that the tumor has, whether it is a poorly differentiated or well-differentiated tumor, and the higher death rate when patient presented with a poorly differentiated or undifferentiated tumors. Because these patients can have the incidence of distant metastatic disease is higher. Of course, extracapsular spread presence in the specimen shows that the patient has a poor prognostic factor. This is interesting because when we talk about the margins, it always, when we resect a tumor, we always talk about whether it is adequate, close, or positive margins. So we can divide into two. One is clinical margins. We always take about 1 to 1.5 centimeter. And after that, we look at the pathology after fixate by ethanol. So the pathological margin should be at least 5 millimeter wide in the resection specimen. And we take about more than 5 millimeter as a clear margin, between 1 to 5 as a closed margin, and if it's less than 1 millimeter positive margin. This is a pathological margin I'm talking about. So recurrence rate of 15 to 30% when the resection margins are satisfactory, compared to up to 80% rates when the margins were unsatisfactory. We can discuss more in terms of how we take the margins, either we take from the specimen or we take from the surgical bed. I'd like to draw your attention to this nice paper about intraoperative margin assessment in the head and neck cancer. And the plot is a nice graph. If you look at the x-axis is about closest margins in millimeter, and in the y-axis is a 3-year local regional recurrence survival probability. And they also include the perineural invasion, whether it's presence or absence. So the one in orange is perineural invasion is present, and the one in black it is absent. So if you look at the x-axis, the arrow at the x-axis is 1 millimeter margins, and then the vertical arrow is 0.7. So what does it mean? If the patient has a 1 millimeter margins, and then there is a presence of perineural invasion, it means that the probability of recurrence is up to 30%. So it's important for us to look at the histology to look into all these features. I mentioned about tumor thickness, so it's similar to depth of invasion. And this is another one that we need to look at. Even if you have a small tumor, but if there is a peridural invasion, this is strongly correlated with aggressive tumor behavior, predict disease recurrence, and also decrease survival. And if there is a presence of lymphovascular invasion, again, this also will give aggressive tumor behavior and high incidence of recurrence. They also report on tumor budding and also work pattern of invasion. This is introduced in 1973, and they have a grade 1 to grade 5, and you have a patient with WPOI of 4 and 5. This is associated with a risk of bone invasion, nodal metastatic disease, worse disease specific survival, and of course, they will give high local regional recurrence. What about HPV? I think our colleague mentioned just now, still not established HPV in terms of correlation with oral squamous cell carcinoma. So, ladies and gentlemen, there's some take-home message that I want to share. Number one, patient factors and tumor factor influence the outcome despite a well-executed glossectomy. And number two, we really need to look at the histology. Okay, not just resect the tumor, but we look at the histology. We need to look at the features of peridural invasion, the depth of invasion, tumor budding, and others, because they will determine the risk of recurrence. And hence, surgery alone may not be adequate despite an early tongue carcinoma. So thank you very much for your kind attention, and I would like to acknowledge my senior registrar, Dr. Rachel, for helping me in terms of preparing this slide. Thank you very much.
Thank you very much, Professor Yunus. I'd like to turn the floor over now to Professor Hao for the next, for our last two speakers. Professor Hao.
Well, thank you, Jeanette. This is Simple Hao again. The next speaker, Professor Pankaj Chaturvedi. I think everybody knows Pankaj. He is a giant in head and neck cancer surgery, and really no need for further introduction. Maybe just a few words. I think he is the deputy director at the Center for Cancer Epidemiology at Tata Memorial Cancer Center in Mumbai, India. He is currently also the Secretary General for the IFNOS, the International Federation of Head and Neck Oncology. And I think he is going to share with us his experience in the advanced oral cavity cancer. Pankaj, the time is yours. Pankaj?
Yeah, hi.
I can start.
So everybody can see the slides?
Yes.
Okay. So thank you, Peter, and thank you, Mark, for giving me this opportunity. And what I'm going to do in next 10 minutes is to present our experience in management of locally advanced cancer from Mumbai, and it's the representative of India. Yeah. So first, let me share with you what I mean when I say locally advanced cancer. For me, the right column, that is the T4, N0, M0, T3, N1, M0, these large cancers are ones that I'm going to talk about. I'm not going to talk about the T2, N1s and T1, N2s. And also there are large, huge lesions that we call T10, N0 or T20, N0. We are not going to talk about that. Now, Tata Memorial Center is a Government of India hospital, and we have 6 branches all over India. And between these branches, we register around 130,000 new cancers every year. Of these, 25% nearly are head and neck cancers, of which oral cancer is the #1 cancer. And 2/3 of these cancers are locally advanced. And if you look at the situation here, if in the men, it is the commonest cancer, and it is commonest cause of cancer-related death in Indian men. And the cause of this high burden is high tobacco use, especially smokeless tobacco. And Of course, there are economic issues because of which these patients are not able to visit the clinics. And of course, there is a lack of awareness. And as rightly said by one of the previous speakers, that there is a need of awareness, early detection, screening in this population. Now, talking about the locally advanced cancer, I'm going to make entire discussion is based on these 3 publications that we have done over last few years. First was on 2005, then 2009, and then in 2018. Now, if you look at what we published in 2005, 2009, and 2018 from Tata Memorial Hospital, Mumbai, regarding locally advanced oral cancer, if you see the last column, for T4 lesions, the survival is 65%. For T4, it is 42%. And these are the variety of prognostic factors that we found are implicated in outcome. And this is the overall survival. So what I mean is that the kind of oral cancer that we have in our country, the survival, even after good treatment in a good institution, is not more than 50%. Now, this is another publication that we did, and we again found that compared to early cancer, and this is the latest publication, here again, if we see that more important is that even in a high volume center, if you look at the morbidity and the mortality, so if you do good surgery for even orally, locally advanced oral cancer, the morbidity is around 36% and 0.9% is the mortality. And most of the patients who have complications are the ones who have a node positive and who require microvascular reconstruction. But what is more important is that we are now ushering in an era where our locally advanced oral cancer have nearly 50% survival compared to the previous decade. Now, India being like a epicenter of oral cancer burden, we see a lot of these advanced oral cancers. Now, these advanced oral cancer, as per the TNM staging, because of their infratemporal fossa extension, would be labeled inoperable or stage 4B. But we recently did analysis of our T4, so-called T4B under the TNM, but if it is a low infratemporal fossa disease, we still prefer surgery. And what we found, that if you are able to operate stage 4B as per the TNM because of the infratemporal fossa extension, if negative margin is there and patient does not have a high nodal burden, then their survival is as good as T4A or some of the T3. And therefore, surgical removal of low infratemporal fossa tumor should be our priority rather than labeling them and sending them for chemotherapy or radiotherapy. The other issue is that many a time we do not have MRI or CT scan in different parts of the world and certain parts of India and developing world also. So what do we do for taking the margin in the bone? And recently we found this study and we published it, that if we are able to achieve 1.5 centimeter margin beyond the palpable edge of the tumor, you are able to achieve a negative margin. Of course, this does not include those patients where we get radiological surprise, especially in the elderly people where the horizontal spread is much beyond the palpable tumor. Fortunately, most of our patients are young and therefore the marrow is very dense, and therefore this horizontal spread is not as much seen in the elderly population, which may be seen in the West. Another important question that we tried to answer was, when do we do contralateral neck node clearance? And our philosophy is that if this is as per this paper, if you have lesion coming up to the midline or lesion crossing the midline, even if the contralateral neck is N0, we must do the neck dissection. On the ipsilateral side, if you have a large neck node, N2, N3 neck node, then the chances of contralateral node is positive. And therefore, on clinical examination and on radiological and clinical finding of the ipsilateral metastasis, we decide on the contralateral neck node dissection. Similarly, because we see so many locally advanced oral cancer, some of them they do well, some of them they do not well. Can we distinguish the good performers of stage 4 oral cancers? I'm talking about the operable stage 4 oral cancer from the bad performer. Now, in TNM staging, both will be called stage 4. But if we use the nomogram and we used it in our subset of the patient, if we use the cutoff value after the entire mathematical calculation as 13.5, looking at variety of other factors apart from T and M, we can find a good subset of the patients who have good survival and those who have bad survival. Perhaps nomogram is the future of staging, and this will allow us to escalate the treatment in those stage 4 who are likely to have a poorer outcome in the future. Now, the next issue that we always face in our clinic is the locally advanced cancer, which is borderline resectable. That means it is not clearly unresectable, and it is certainly not a very early disease. Now, in this patient, if you see that there's an edema going up to the zygoma, there is a temporalis masseter muscle involvement. These lesions, if you try to do surgery, there is a cutaneous spread along the lymphatics, and sometimes we get margin and the failure rate is very high. So these lesions are very common, and in these patients, what we practice is induction chemotherapy. We give them 2 cycles of induction chemotherapy. If they respond well, we give the 3rd cycle of induction chemotherapy. And what we found in our subset of the patients, those who respond well, they undergo surgery, and after surgery, again, they undergo concurrent chemoradiotherapy. Those people and patients, they have a better survival compared to those who do not become resectable. So this is a standard of care induction chemotherapy. Now we are doing a randomized control trial on that. Last subset that we have, very common in India, is that primary tumor is small, but we have a large N3 neck node. Now, one way to call them is that you call them stage 4B and do not resect them. However, this being a very common and patients usually being very young, we tried induction chemotherapy again in them. And what we found that after giving induction chemotherapy, we get favorable response in 64%. 87% were amenable to, of these who respond well, a curative intent. If you are able to perform surgery on these who respond well, their survival is 24 months compared to those who do not respond and they undergo either palliative chemotherapy or radiotherapy. So at the end, I would say that locally advanced oral cancers are a very diverse group of disease. Surgery, whenever possible, is the mainstay of the primary treatment, followed by adjuvant treatment. Low ITF extension is still amenable to surgical resection. Induction chemotherapy offers higher control rate in the borderline resectable patients, and nomograms are superior to TNM in prediction of the outcome. Thank you so much.
Thank you, Pankaj, for your wonderful lecture. I think well, we might have some questions, towards your talk. We will leave it at the end. Thank you, Pankaj, again. So I'm honored to introduce to you one of my best friends, Professor Zheng Minghui. Professor Zheng is a professor in the Department of Prostate and Reconstructive Surgery, Chung-Yu Memorial Hospital, Taiwan. And we have been working together especially for oral cavity cancer when I work in Chung-Yu Memorial Hospital for 20 years. And I think Professor Zheng is really a very experienced reconstructive microvascular surgeon. I think he operates on more than 2,000 head and neck cancer patients, in his whole career. So we are honored to have Professor Zheng with us today. Professor Zheng Minghui.
Thank you, Professor Hao, for a great introduction. It's my great honor to share with you my experience in reconstruction in oral cancer. This is my disclosure. The general principles of reconstruction for oral cancer include assess the defect and prepare the recipient site, select the donor flaps, flap harvest, flap inset, then anastomosis and wound closure. And which flap shall I use? And first of all, we need to assess the defect and see if we need a bone for the reconstruction. If the answer is yes, then the first choice for the bone flap is a fibula flap. Then we look at do we need the volume for replacement of the defect or obliteration. If the answer is yes, then we can use the osteomyocutaneous peroneal artery combined flap. If we don't need volume for the reconstruction, we can use a fibula osteocutaneous flap. If we don't need the bone, then we look at the soft tissue flap. And we ask, do we need the volume for the defect? If the volume need to adequate to apply the reconstruction, we need an anterior lateral side flap with a VL muscle, vastus lateralis muscle. If we don't need the flap, we can use a fascial cutaneous flap, either the thin flap or pliable, or we need a bigger for the territory, we use the ALT flap. There are 4 recipient sites on each neck available, such as this. You can see. You can see the most common recipient site were facial artery and the superior thyroid artery. And if they are not available, special for the recurrent case, we can use the superficial temporal artery or transverse cervical artery. Now I'd like to introduce the most common bone flap, fibula flap. In 1997, Ian Taylor introduced the fibula flap without skin pedal. In 1986, Dr. Hu Cheng-wei addressed the osteocutaneous fibula flap with the addition of the skin pedal for the coverage. In 1989, David Hidalgo from Memorial Sloan Kettering applied the fibula flap for mandibular reconstruction. This cartoon showing the evolution of fibula flap from fibula bone only flap to fibula septocutaneous flap to osteomyocutaneous peroneal artery combined flap. In 2006, we invented the osteomyocutaneous peroneal artery combined flap to incorporate of psoas muscle based on peroneal artery perforator to create a combined flap that is useful for mid-facial and complex mandibular reconstruction. The osteomyocutaneous peroneal artery combined flap include 1 to 4 segments of fibula bone, 2 separate skin pedals, and 1 segment of solid muscle based on a single pair of peroneal artery in the vein, and require only 1 pair of vessel anastomosis. In 2012, we described this transmandibular defect stage. For the stage 2, that means 2 layer, either bone with 1 intraoral mucosa or bone with the external skin or bone with the external skin and soft tissue, referred to 2A, 2B, and the 2C stage. For the transmandibular defect stage 3, refer to composite 3 layers of defect. And 3A means the 3-layer defect, 3B, in addition to composite 3-layer with a partial tongue defect. 3C refer to composite 3-layer and the partial maxillary defect. The indications of OPMD include transmandibular defect type 2C to 3 and collateral defect 2 to 3. The surgical technique of OPMD. First of all, we like to use a pencil Doppler to map in the subcutaneous perforator in the middle and the lower junction of the leg, and followed by another plasma one-third of the myocutaneous flap, such as in this picture, we measure the defect of the composite mandibular defect, and with the pencil ruler as a template to measure the length and the segment of the fibular deep segment. We use a whiteboard to draw in all the defects on the whiteboard at OR. Then design the flap with a pencil Doppler mapping the perforator. Then we split the skin petal into two parts, one for intraoral lining, one for external cheek defect. Then we start to insert the flap after the flap transfer to the recipient side, and using the bone fixation with the reconstruction plate. Sometimes use a mini plate, and then pedicle had to be pressed into the approximate position, such as this picture. You can see the fibular bone was fixed to the reconstruction plate, and after the temporary IMF, then the pedicle pressure underneath the fibular bone. And in this picture, just for picture to see the course of the peroneal vessels, then the soleus muscle flare on top of the fibular bone and the reconstruction plate. Then suture the two skin petal, one for intraoral lining, one for external cheek. Another example of stage 2 bone and the intraoral lining defect. And as you can see, temporary IMF reconstruction plate, paper template for tearing the fibular bone, and two segments of the bone. The pedicle was scatterized to reach the recipient side of the superior thyroid artery, and the segment of soleus muscle cover on the top of the reconstruction plate and the fibular bone. And here is a 2 years post-op. As you can see, the CT has a good alignment of the reconstructing bone, and the plate cover with a soleus muscle segment to achieve better cosmesis. Here is a result of the recipient side, and the donor side mobility is minimal. Another case of type 3A, the bone intraoral lining and the external cheek skin defect. Here you can see the defect, and the defect drawn on the whiteboard, and a tower for the template of the skin petal. And here you can see the paper ruler as a template for the osteotomy of the fibular bone. And this composite OPEC flap include 3 bone segments, 2 skin petal, and 1 soleus muscle. And after the flap insert, the bone fixation, the intraoral skin suturing, and soleus muscle flare on top of the plate and the fibular bone. Here is the immediate post-op and 6 months post-op radiation. The donor side. Another case, OPEC flap for composite muscular defect. As you can see, the defect involved nasal lining, palatal lining, and muscular sinus. So this is a composite OPEC flap design, and also the harvest. And this is a result. As you can see, the muscle has been reconstructed. The globe, the eyeball has not dropped without diplopia. The muscular sinus has been successful tightness with a good nasal lining. The advantage of OPEC flap include independent 3 components and facilitate the easy 3D flap dissection with only 1 donor side, 1 pair of recipient vessel for anastomosis. There was an economic design of the skin petal, and the dead space can be obliterated, and to decrease the plate exposure after radiation. The soft tissue augmentation with the solid muscle can provide better cosmesis and possible osteointegrated dental implant. The disadvantage of OPEC flap include delicate dissection of perforators, a steep learning curve, complex perforators and the component, and care should be avoid twist kinking or compression of the perforator and the pedicle. How about the soft tissue, the flap for the reconstruction of the after buccal cancer resection? First of all, we look at the anterior lateral side flap. The indication for anterior lateral side flap include buccal defect, subtotal and the total tongue defect, through and through defect, mandibular defect, maxillary defect, esophageal defect, and scalp defect. The ALT flap based on the lateral circumference of femoral artery descending branch and giving several septocutaneous perforator, sometimes myocutaneous perforator. So the skin pedal design can be elliptical, rhomboid, and pentagonal. For the subtotal the tongue defect, we use a rhomboid shaped skin pedal design. And here you can see the cartoon. And this is a real case that we have ALT septocutaneous perforator flap harvest, and at the insert to the tongue defect, immediate result. For the total tongue reconstruction, we like to have this kind of pentagonal design. The skin pedal bigger than the VL muscle. Therefore, the skin can wrap around the VL muscle to form a good shape similar to the original tongue. Here, the example of the total tongue defect. The skin pedal design 15 by 10 centimeter, the muscle around 10 by 5 centimeter, and we harvest and then insert to form a new neo tongue. Then we look at the fascial cutaneous flap, and the first choice is a forearm flap. The indication of radial forearm flap include hemi-tongue defect, buccal defect, palatal defect, upper and the lower lip defect, and nose defect. Here you can see we like to use a suprafascial dissection. Therefore, we keep the deep fascia intact and very easy to put a skin graft on top, either the split skin or full thickness skin graft. For the hemi-graftectomy defect, we like to use a forearm flap, and here you can see the rectangle design and flap inside and donor side. The advantage of radial forearm flap includes thin and flexible skin pedal with a long and reliable pedicle, very easy to harvest. The disadvantages include sacrificing a major vessel, the donor side mobility, and possible ischemia of the hand. Therefore, the modification of radial forearm flap will be another ulnar forearm flap. And there are several papers being published. And here is a cadaver study showing that radial artery dominate in the distal forearm. So if you're familiar with this anatomy, should be choose the ulnar artery instead of the radial artery forearm flap. Here you can see the perforator of the ulnar artery, usually 4 to 5 septocutaneous perforator available in this territory. Therefore, this flap is very reliable for the thin skin defect, mucosa defect. Such as this buccal defect, we use ulnar forearm flap and reconstruction after 1 year follow-up. Another case, there's a hemi-tongue flap, use a ulnar forearm flap, and 2 years of follow-up, the donor side scar. In conclusion, the surgeon had to be familiar with all the anatomy surgical technique or most common use donor flap. The strategic approach for hand neck reconstruction may achieve predictable better outcomes. Thank you for your attention.
Well, Thank you, Professor Zheng, for such a comprehensive and wonderful lecture. I think there's a lot of questions, toward each speakers, and some of the questions has been covered in the lecture. However, there are still some have not been well answered. So I will ask my co-moderator, Jeanette, will you take over and try to answer all the questions, or appoint someone, some speakers to answer the questions?
Okay, Dr. Hao. Some questions were submitted during the registration period. So some of the questions we received in advance. So I'd like to ask them because they have not been answered yet as of today. There are a few questions for Dr. Chung-Yu Hao. Dr. Hao,
Yes.
how would you manage carcinoma in situ of the tongue?
For carcinoma in situ, we usually do a adequate lesion biopsy for the lesion, so for check for any possibility of develop to oral cancer. And we usually, if it's the pathology shows CIS lesions, then we usually just do a incisional take out the tumor, the CIS lesion.
Okay, thank you, Professor Yunus. Would you manage it similarly or any different? Carcinoma in situ of the tongue. Professor Yunus?
Yeah, thank you, Janet. So I think, similar answer that we need to resect the tumor, and then the primary treatment is always resection, and then we should go for a regular follow-up to look at any incidents of recurrence.
Okay, thank you. Related to that, there was a question here about laser for pre-malignant lesions, for oral pre-malignant disease, the use of laser as treatment. Dr. Hao?
So in our experience, we don't really do laser surgery for oral potentially malignant disorder, because for this kind of disease, it's very important to get a adequate and representative biopsy for the lesion. So if we do a laser surgery, we don't think we can get enough specimens for adequate pathology results. So we rarely do laser surgery for potentially malignant disorder.
Dr. Matsu, I had one comment. I really appreciate the comments of Dr. Hao and Dr. Yunus and their expertise. Just wanted to add, we do typically at our institution, just to add to what they were saying, we typically divide these pre-malignant lesions into mild, moderate, and severe dysplasia in terms of pathologically. And those that are mild dysplasia, we do in fact laser some of those that are mild dysplasia. They have a pre-operative biopsy. It suggests mild dysplasia, and then we do use the laser for some of those. If they have moderate or severe dysplasia pathologically on the biopsy, then we don't tend to use a laser. We tend to just resect those. So that's just to add, our particular experience to that.
Okay, thank you, Dr. Zafareo. If the other speakers have any want to add anything, please feel free to do so. One last question for Dr. Hao. Relationship of acid reflux to oral cancer. Dr. Hao, is there any relationship between acid reflux and oral cancer?
So can I take that question, Janet?
Yes, Professor.
Okay,
Dr. Pankaj.
So there is no correlation between reflux and oral cancer. And stepping back, one thing about a laser, one word of caution that I have, I agree with Mark that based on the degree of dysplasia, you may use laser or not. But one issue that I must stress upon, that there is no role of fulguration, because a lot of time people use laser to fulgurate a leukoplakia, and there is no treatment like that. The reason is that you miss the opportunity of a histopathological examination of the specimen. And therefore, whenever you are doing laser, it's a tool for wide excision or for an excisional biopsy at times.
Okay, thank you very much. Dr. Hao.
May I
Yes.
speak?
Dr. Shenko, yes.
Yes, I completely agree with Pankaj that we don't routinely use laser for vaporization because I think Dr. Hao is very clear that we need to really examine the OPMD, the degree of dysplasia, and if you just vaporize the lesion, then you will lose the chance to look at the degree of the dysplasia, which is a hallmark of malignant transformation. And then some of the techniques for, some of the, for example, the severe dysplasia or carcinoma in situ, it's our experience that some of the lesions, within the lesions, there are some focal or malignant transformation to become a squamous cell carcinoma already. So we actually published a paper on the so-called excisional biopsy in head and neck. That is, we would, in any cases with CIS, preoperative diagnosis with CIS or severe dysplasia, we will do excisional biopsy and we will send intraoperative frozen section to make sure it's not cancer. And then to check the surgical margin, of course. So I think it's our practice, and just because, if you have a operative CIS or a severe dysplasia, there's still a high chance a diagnosis of a cancer after the permanent pathology diagnosis. So we've been very cautious to treat this kind of pre-malignancy. Thank you.
Okay, thank you, Professor Dr. Peter. There have been new questions posted in the Q&A box, so let me go back to them first for the advanced questions. Since we are still on early stage and pre-malignant lesions, there is a question here: should all leukoplakia patches be sent for biopsy? Maybe Dr. Chen can answer this one.
Sure. I think so. There are a lot of different causes of leukoplakia. It probably depends on the clinical scenario. If they have risk factors, if for either it could be thrush, or if there's risk factors for malignancy, like if they are betel nut chewers, have a significant smoking and alcohol risk. I think in general, in addition to just taking the entire patient into account, if you're worried enough, probably the most conservative approach is just to do a biopsy, although knowing that you could have a sampling error as well if it's a large lesion of leukoplakia. So I think it's a challenging answer to ask, or challenging question to answer, because it depends on a lot of different nuances, but in general, probably better to biopsy a lesion that hasn't resolved after appropriate treatment.
Okay, thank you, Dr. Chen. Would you routinely test for P16 in tongue cancer? Dr. Chen, P16 in oral cancer, tongue cancer.
I don't think so. So far in the literature, there hasn't been any literature that has suggested that P16 really plays a role in oral cavity cancer. So far, it's just to the oropharynx. I know that there are some studies out there that do suggest potential connection of P16 with some sort of prognosis in other non-oropharynx cancers, but at this point, there isn't any definitive data in the literature to suggest that P16 plays an important role in oral cavity cancer.
Okay. There were questions also similar to this that were answered by our speakers earlier. in the Q&A box. For Professor Yunus, Dr. Hao? Yes, Professor Hao.
Yeah, I think there are also some questions toward the reconstruction, especially on the total glossectomy. How would you reconstruct the total glossectomy wound, or how would you reconstruct the glossectomy include some of the tongue base? So probably Professor Zheng Minghui, would you like to answer these questions?
Which one?
The glossectomy defect. How would you reconstruct the total glossectomy defect, and would the reconstruction really help the patient swallow? And is there any swallow function recovery after total glossectomy reconstruction?
Yes, this is a very interesting case. For the total glossectomy, I think the hyoid bone usually still exists. So if you reconstruction can provide adequate volume, when the hyoid bone move up and the neck a little bit flexion, the reconstructed flap can reach the palate. The patient may have some swallowing function. So like this, and the neck flexion and the hyoid bone push up, the reconstructing flap can reach the palate. So you can see my design, the pentagon skin pedal always wrap around the velar muscle. They can provide adequate volume to reach the palate. So with this kind of reconstruction design, the patient can achieve, actually can eat the soft diet. Sometimes they use with the assist of the chopstick move around the foot from the teeth to the center of the reconstructing flap. They can reach up to the palate, so they are able to swallow it. And the speech will be also much better. So very often, if you only reconstruct the defect with a flat, very thin flap, the end result actually the reconstructed flap cannot reach the palate. So the speech is not good, and also swallowing function not good. Thank you.
Thank you, Professor Zheng. I think I will ask Pankaj further. Because you talk about the advanced, oral cavity cancer, some questions regarding the resectability. How would you consider a patient oral cavity cancer is irresectable? Pankaj.
So, correct. So if for tongue cancer, you have disease going up to the base of tongue, to the vallicula, and maybe supraglottic area. Another involvement of oropharynx, if it is there for tongue cancer, these are considered unresectable. But for us, what is more important is that if you cannot achieve a free margin, that is 1 centimeter on table for a tongue cancer, it is considered unresectable. Now we may do a composite resection, such as tongue with mandible, tongue with oropharynx. These are fancy surgeries. Here we have realized that the outcomes are not good, and therefore we practice induction chemotherapy wherever tongue composite resection is required along with oropharynx and mandible. The second set is for buccal mucosa. If you have the lesion which is involving the masseter up to the high ITF below the zygoma, if the temporalis muscle is involved, if it is because of the neck, then if the carotid artery is involved, if the structures like prevertebral fascia is involved, these are the unresectable oral cancers.
Yeah, so may I ask one more question? Because you talk about the neoadjuvant chemotherapy for advanced neck disease, and I think some of the participant asked, how would you decide the surgical margin? I mean, the primary site, surgical margin, because if you use the neoadjuvant chemotherapy for, cervical disease, and then you face the same problem, how would you treat your primary disease? How would you decide the surgical margins?
So most of our studies, when we do induction chemotherapy, the surgery is as per the post chemotherapy assessment by the clinical radiological examination, and whatever is the remnant disease, we do the surgery as per that. And this emanates from the fact that in the Lisa Lisitra study, our own publication in the JCO recently, that if you give induction chemotherapy, organ preservation is possible. That means we can do lesser surgery followed by induction chemotherapy based on the shrunken disease.
Thank you. Any comments from Razif?
Yeah, thank you, Prof. Shenko. Just from a clinical experience, I agree with Pankaj about induction chemotherapy, but in our series, most of the time they don't achieve the shrinkage of the tumor, and these patients usually, they are not the best candidate to receive a full dose of chemotherapy. So most of the time, halfway they stop because of they can't tolerate the chemotherapy. So we don't really do this induction chemotherapy. And if the patient, until to that stage, we will call it like, is inoperable, and we treat palliatively. So not much in our center that we perform induction chemo and followed by surgery. But yeah, that's what we are doing in our center.
So Jeanette, how about in Philippines?
Similar to India, Professor Hao, we also get this big oral cavity cancers, and oftentimes those with really unresectable necks. If the patient is a fairly good surgical candidate, like young with not so much comorbidities, we might recommend doing an induction chemotherapy prior to definitive surgery. But this is an exception rather than a standard practice.
Thank you. I think we still have some time, so probably we will ask one or two more questions.
Dr. Ho.
Yes.
I had a question that was actually brought up by one of the speakers that we haven't touched on yet, which is the role of sentinel lymph node biopsy in oral cavity cancer. Just to see if you or Dr. Chaturvedi or others have comment on that.
So sentinel node biopsy, my personal thought is that if it is done for early oral cancer, that is T1 and early T2 in clinical radiologically negative neck, this is an option. However, I would suggest that this is not something which is proven beyond doubt that it is beneficial, and therefore, if you do not have the facility for sentinel node biopsy, which is very labor intensive, cost intensive, and time intensive, there are two surgeries required, step serial sectioning required, you require a SPECT CT scan, you still require MRI sonography. So basically, it is complicating a simple supraomohyoid neck dissection, which takes 30 minutes extra during the surgery, converted into a 10 days program for the patient. So this is a choice that the patient and the doctors have to take together based on the infrastructure and the demand from the patient that they have.
Thank you, Pankaj. Yep. And so we almost have 10 minutes. So maybe the last question toward Stephanie and Chung-Yu. Is there any law for chemo prevention for the OPMD at this moment? Stephanie?
When you say chemo prevention, you mean like smoking cessation, or what do you mean by chemo?
Not a behavioral detour. It's something like using retinoic acid or the chemo prevention.
I see. Like potential therapeutics.
Yes.
That's a great question. I think So there are a lot of different types of oral premalignant disease. So dysplasia was brought up as a pathologic diagnosis. I think there's certain inflammatory conditions such as lichen planus that have some studies show there is some associated risk with development of oral cavity cancer. So in those patients, close surveillance and treatment of lichen planus with assistance of dermatology is probably very useful, or rheumatology. But in terms of non-inflammatory conditions, I think because poor dentition has been associated with oral cancer development as well, going to the dentist regularly, that could be encouraged for patients, not really a drug, but just routine dental cleanings, because some studies may suggest certain bacteria or other inflammatory conditions caused by poor dentition could be associated with oral cavity cancer. But otherwise, I don't personally know of any, but maybe someone else is better equipped to answer that question in terms of therapeutics for patients that have different degrees of dysplasia and what you could use in terms of that. But I do think molecular diagnostics has the potential to identify potential targets. So if we knew one biomarker was expressed in oral premalignant disease and was strongly associated with the development of oral cancer, we could potentially target that molecule and give like if it was an antibody against that receptor, for example, that would be very exciting. But at this point, I don't know of any specifically.
Yeah, thank you, Stephanie. I think at this point, there is no proof, a study or any known data strong enough to support the chemo prevention for to prevent the OPMD for their malignant transformation. I totally agree with you. If we could find a target, a molecule, then we probably would, animate the target and try to, prevent its malignant transformation. However, all the studies till now just failed. So that's my understanding. Well, thank you. I think today we have a very good, a discussion on oral cavity cancer from the screening, prevention, molecular diagnosis, and using the, some of the screening protocol, try to help our patients to the, management of the advanced cases. And certainly for surgery of the advanced cases, we need reconstruction. So that brings Professor Chen into the team. Thank you for everyone for a very good, participation, especially for the participants. And so thank you for all. Jeanette, you have something to say?
I just like to thank everyone for a very good discussion tonight. And we're happy to see so many participants so actively engaged in the question and answer. Thank you, Dr. Hao.
Yeah, thank you. So I think, Mark, you have some announcement, right? So
we just have about 2 or 3 minutes left. Just a couple of quick announcements. First, I cannot thank Dr. Hao and Matsuo enough and our illustrious panel for such an active and thoughtful presentations and discussion. Always a lot to learn in this arena of oral cavity cancer. So just briefly, our next global grand rounds, we have these global grand rounds 4 times yearly. Our next one will be November the 5th at 9 a.m. Eastern US time, and it will be disruption and innovation in otology and neuro-otology. So really a lot about the latest and greatest in technology and techniques that will be discussed. So we look forward to that global grand rounds in November. But before that, we have our live annual meeting in September in Philadelphia. You can still register for this, obviously online, and we hope to see as many of you as possible there. We have guest countries, Argentina, Japan, Nigeria, and Spain. So there's a special even discount for participants from those countries. And then just to mention, again, we welcome any of you to become international members of the American Academy of Otolaryngology Head and Neck Surgery. There are special international membership rates, and Mrs. Katie Grimes we'll be sending all of you some of the links in the email with further information about this. So with that, thank you again to Dr. Ho, Dr. Matsuo, for moderating this great panel. Again, our speakers, Dr. Hao, Dr. Chen, Dr. Yunus, Dr. Chaturvedi, and Dr. Cheng. Just wonderful presentations, masterful, and discussions. We look forward to seeing all of you in Philadelphia and at the next Global Grand Rounds in November. So with that, good morning and good evening, depending on where you're on the world. Thank you.
Thank you, Mark.
Thank you.
Thank you.
Thank you, Mark.